Yeah, my job, sort of like Jan, he's sort of giving you what he thinks the JNC 8 is going to be. It's my job to sort of tell you what I think the Adult Treatment Panel 4 guidelines are going to be. I think, Jan, you're right. They're going to sort of roll something out at the AHA in a couple of weeks. I'm not sure exactly how it's going to be. Hopefully it'll be a few bullet points about some things, and then the publication will come out sometime in the spring of next year. But what I'm going to tell you is that the last time the Adult Treatment Panel came up with an update, it was in 2004. And what has happened since 2004, and how will this impact what will happen in the ATP IV? Well, less than 70 milligrams per deciliter on LDL cholesterol has been called a reasonable target in secondary prevention by the American Heart Association. The defining level for HDL cholesterol has always been less than 40, and that included for women as a risk factor. Well, since 2004, the American Heart Association and others have said that the risk should be based on gender, so it should be less than 40 in men, less than 50 in women. We got a lot more information about primary prevention of cardiovascular events by statin treatment, and that came in the Jupiter trial, and I'll show you that in a moment, but especially for the first time demonstrating benefit in women for primary prevention and elderly in primary prevention, if we call elderly greater than 70. There's a lot more data now about the cardiovascular risk of metabolic syndrome, not only identifying it, but it's going to be used in risk identification, and it'll move patients to higher risk categories because of the presence of the metabolic syndrome. What we have learned since 2004 is that we have no data about the benefits of statins in end-stage renal disease. I'll show you that. We have no data that we benefit class 3-4 heart failure by using statins, that we do not benefit dementia by using statins, and we don't benefit the progression of aortic stenosis to valve replacement by using statins. We do have some benefit in chronic kidney disease that is not dialysis dependent, and I'll show you that. We do show that there's some incremental benefit above and beyond statin treatment with the use of fibrates combined with statins with patients who have low HDL and high triglycerides. That's in the ACCORD group. Jan showed you what they showed in the hypertension part of the ACCORD, and I'll show you what they showed in the lipid portion. But there appears to be no incremental benefit of a niacin added to a statin, at least in a population that I'll show you about in the AIM-HIGH study, which will be presented at the American Heart Association in 2 weeks and will be published in the New England Journal of Medicine at the same time. So what do I think the ATP IV should look like? Well, I think, first of all, there should be more emphasis on identifying the primary prevention candidates for heart disease. It's a no-brainer for patients to say, look, I've had a stroke, I've had a bypass, I've had an angioplasty, I got peripheral vascular disease. What are you going to do for me now? Well, of course, we're all going to jump in and do a lot of secondary prevention. But how do we identify the person who says, I want to prevent my first vascular event? Who are they? What's the best way to do it? Do we use biomarkers or subclinical measures of atherosclerosis? I think the group is going to have to find a cost-effective, reasonable way to do that. LDL cholesterol served us very well for over 25 years as a target of treatment, and it will continue to be so, but it's not the best target. ApoB, non-HDL cholesterol particle number are probably better, particularly in some patient groups, particularly those with insulin resistance, and I'll show you that. The question is whether there's incremental benefit on top of optimal statin treatment once you've got somebody to an LDL cholesterol goal. The question is whether niacin has a role. Probably not, as far as we can tell right now. Fenofibrate probably if you have low HDL and high triglycerides and you're insulin resistant. We have no idea what to do with omega-3s on top of statins and what patient population they benefit. And if we're trying to figure out what the driver of incremental benefit is on top of statins, for instance, is it the presence of low HDL, so therefore we need to increase it? Is it because patients have too many particle numbers like ApoB, which we haven't been measuring? Or is it a combination of both? Well, we'll have to, I'll present what I think they ought to do. There's also going to be a lot more emphasis on chronic kidney disease as a risk category, and there'll be some statements about the periprocedural use of statins, which you guys don't need to know about, but which cardiologists will. To give you a highlight of what I think the ATP IV will look like, you can look at what the Europeans just put out 3 or 4 months ago. This is their updated guidelines published in both Atherosclerosis and the European Heart Journal in July. I don't think the Europeans know anything different than what we know. They look at the same data that we look at, so if this is what they say, I suggest we'll probably be very close. They have a risk-based approach, which we continually will recommend. They use a different scoring system. It's actually called a score, and their score is on fatal cardiovascular events, which is about 1/3 the risk of the Framingham risk score. So when they say a risk of 10% 10-year risk is high risk, very high risk, it's equivalent to about a 30% Framingham risk score. So they have a high-risk category, which is anybody with documented cardiovascular disease, whether it be invasive or non-invasive, including the presence of carotid plaque, aortic aneurysms, etc. Type 2 diabetes with heart disease and chronic kidney disease is in the highest risk category. Type 1 diabetes with evidence of end organ damage is very high risk in anybody with chronic kidney disease. The high-risk category are people who have markedly elevated single risk factors, severe hypertension, or genetic cholesterol abnormalities. Type 2 diabetes at any age. That includes all your 18-year-olds with type 2 diabetes. And anybody who has a score category between 5 and 10%, which is equivalent to 15 to 30% on Framingham. And then the moderate risk is usually your primary prevention categories down here. And this is usually people with family history or low HDLs or genetic lipid problems as well. Their lipid targets are still going to be LDL, that's what they recommend, but they also talk about alternative targets like non-HDL and ApoB, and they consider those alternative. They would rather you look at non-HDL and ApoB if you have mixed lipid problems, insulin resistance like type 2 diabetes or metabolic syndrome, or another insulin resistant state, which is chronic kidney disease. They don't give any targets for HDL and triglycerides. We never have. We tell you what's acceptable and what's a risk, but we don't tell you to target them with treatment specifically, and the new guidelines, they don't do that either. Look at their cut points based on risk. Their LDL cholesterol is less than 70 if you're high risk, very high risk, and that corresponds to an ApoB less than 80 and a non-HDL cholesterol less than 100. They also make it very clear that in very high-risk individuals, you should strive to at least lower LDL cholesterol 50% from baseline, no matter where they start from. And I think that's very important because, you know, generic statins at starting doses don't give you 50% lowering. So why do it in these high-risk individuals? I mean, you need to use high enough dose statins. So your high risk and your moderate risk groups, they've got LDLs less than 100, ApoBs less than 100, and high risk. And their moderate risk, since they talk in millimoles per liter and we talk in milligrams per deciliter, the equivalent for us is a LDL less than 115 if you're primary prevention. Interestingly, they go even further, and I think this is what they'll do in our guidelines as well. There is no recommendation for testing routinely lipoprotein particle size. You don't need to do Lp(a) except in very specific situations, which is premature coronary heart disease personally, or a very premature family history of heart disease in a first-degree relative. Genotyping is not recommended. So all these gene tests that are out there that patients can get for $1,000 telling them they might be at risk for things doesn't help you identify risk, and it's not recommended routinely. High sensitivity C-reactive protein probably will be a risk identifier, but it is not a target of treatment, so it should not be followed routinely in patients. And notice they talk about some special populations, which I think is really important, and one of those is autoimmune chronic inflammatory diseases are considered high-risk patients. That's anybody with rheumatoid arthritis, a collagen vascular disease, psoriatic arthritis, and older individuals should be considered for primary prevention, including over the age of 70, which I'll show you some of the data to support that. All genetic dyslipidemias, which you can find in the pediatric group, should be addressed at any age and should be considered for even diet and drug treatment. Now I'm going to show you some of the data that has come out since the last ATP III, which is a meta-analysis of statin trials involving 170,000 patients in controlled clinical situations. And this is a cholesterol treatment trialist collaborative group, and they looked at the event reductions for a 40 milligram per deciliter reduction in LDL. Actually, that's a 1 millimole per liter reduction. This is a linear response. So if you get 80 milligrams per deciliter reduction from baseline, you would get twice this benefit on cardiovascular events. If you look at these trials, these are more versus less intense statin treatment on any cardiovascular event, any coronary revascularization, or any stroke. If you look at the open diamonds, you get a minimum 20 to 25% reduction in each one of those for a 40 milligram per deciliter reduction in LDL cholesterol from baseline. That's comparing more intense versus less intense statin treatment. If you look at statin versus control, just taking a statin versus taking nothing, much more data, many more patients. That's why the confidence intervals are much tighter. But for a 40 milligram per deciliter reduction in LDL cholesterol, the open diamonds, again, on any major coronary event, any revascularization, and any stroke is at least 20 to 25% reduction. This also translates into, for a 40 milligram per deciliter reduction in LDL cholesterol, a 10% reduction in all-cause mortality. So lowering LDL cholesterol with a statin makes you live longer. The other thing, you'll have to look in your handout later on maybe to see all of this, but I want you to look at it. This is all the subgroup analysis, all the pre-specified subgroups of patients you can think about with statin treatment. 1 millimole per liter, 40 milligram per deciliter reduction in LDL cholesterol works in everybody under every situation. Age, gender, low HDL, high HDL, hypertension, no hypertension, smoking, no smoking. It all works. And even more impressively, they looked at baseline LDL cholesterol levels. And I get this question a lot, and we can talk more about this, I think, in our Meet the Expert. If you look at less than 2 millimoles per liter, that's a baseline LDL of 80 or less. If you lower it 40 milligrams per deciliter from there, you get a significant 22% reduction in all major cardiovascular events. There is no floor below which you should continue to lower LDL cholesterol in high-risk individuals, at least from randomized clinical trials. Let me focus a little bit more on this primary prevention part, which I think is where we can make the biggest impact in preventing cardiovascular disease in patients. And this we've had a couple of trials back in the 1990s, mostly done in men, that showed that there was a benefit of using a statin versus placebo in preventing first major cardiovascular event. But it was the Jupiter trial in nearly 18,000 patients, which included 6,800 women, that showed that primary prevention worked in women just as well as it did in men. We made the assumption that if it worked in men in primary prevention, it would work in women, but we never really had the data until the Jupiter trial came out. And I'll just show you, it was men greater than 50, women greater than 60, who had an LDL cholesterol less than 130, their baseline was 108, whose C-reactive protein was more than 2. And they were not given a piddling dose of a statin, they were given rosuvastatin 20 milligrams a day. They were randomized to that versus placebo. Told you they had 6,800 women, quite a few patients had the metabolic syndrome. I think you've seen this data. The trial was stopped early, it was supposed to go 5 years. It only went 2 because it reduced the primary endpoint, which is this composite up here, 44%. And look how fast it happens. I mean, the event reductions were quite remarkable. The mean age of the patients was 66. And guess what? Primary prevention, all-cause mortality was significantly reduced, 20%. So once again, you don't have to have heart disease to live longer by lowering LDL cholesterol. You just have to be high risk for having heart disease, and lowering LDL and taking a statin will work. And again, if you look at the pre-specified subgroups, the benefits occurred in women just as much as men. Age over 65 had as much benefit as age under age 65. I'll show you the benefits in Jupiter of over age 70 in a moment. Whether you smoked or not, your gender didn't matter. All participants, statin was better than placebo in primary prevention in the Jupiter trial. Here's the data published last year in the Annals at nearly 5,700 patients who were over the age of 70 at baseline, who were randomized to take a statin versus placebo. Notice the top line here, and that is the patients over age 70 who had placebo. Obviously, they're a high-risk population. They're old, they're high risk for future coronary events. They had the highest overall event rates. The red arrow is the reduction in events in the over age 70 who took statins. They actually had the greatest absolute risk reduction of any patient group. So they got benefit, and the benefit far outweighed any risk of taking a statin in that primary prevention age group. The other thing I told you about LDL cholesterol, there doesn't seem to be a floor to which you can lower LDL for benefit, at least in the meta-analysis? Well, the Jupiter trial showed that. I just want you to show the time to occurrence of the first event in the Jupiter trial according to their LDL cholesterol achieved. Well, obviously, the placebo didn't have their LDL change at all. So over time, that's the event rates in the placebo group. Here's the event rates if your LDL was above 50. Here's your event rates if your LDL was less than 50. So the group whose LDL on treatment was less than 50 had the best outcomes. There's no detriment to having a low LDL. They have the best cardiovascular benefit outcome. And the last thing I want to tell you about primary prevention, because I get this question all the time from patients. They're 58, 62. They say, I feel fine. I'm okay. I don't feel like I need to prevent heart disease. Maybe when I get older. Maybe we'll talk about it when I get older. Okay? Well, here's the ASCOT study. ASCOT was a hypertension study, and they had a lipid arm as well. So these were primary prevention hypertension patients. And in the lipid arm, it was atorvastatin versus placebo. The trial was supposed to go 5 years on the lipid arm. It was stopped early at 3.5 years for benefit of taking a statin in these high-risk individuals compared to placebo. Well, what they did in the trial was they took a look at the whole group, and when the trial ended, they told the placebo patients, oh, wow, thanks for doing the study, but guess what? You were placebo. The other people got the benefit. So the people who took the statin originally continued to take the statin. The people who were on placebo were given the option to go on a statin. Well, 90% of them said, sure, I'll go on a statin. Then they followed the groups for another 7 years. The original placebo group never catches up. This is all-cause mortality, non-cardiovascular disease mortality. The lower line is the original statin group. Here's cardiovascular disease death, and here's cancer death. Everybody who started statin and stayed on it for the 11 years is the lower line. They all benefit, no risk of cancer. The group that didn't get it but then started later never catches up to the original group. So when your patient says, oh, I'm too young to start a statin, can I wait until I get older? You're wasting time. The earlier you start, probably the better off you're going to be. Now, the last part I think that's going to be very difficult for the panel, ATP IV, is to figure out whether you can beat a statin by adding any other drug to it. And the reason they've got to ask the question is because in all these statin trials, I have circled the event rates on a statin compared to placebo. These are the 5-year event rates. Compared to placebo, 5-year event rates. Statins don't eliminate cardiovascular disease. They reduce it significantly, but they don't eliminate it. We call that residual risk. And even if you take 80 milligrams of atorvastatin compared to a lower dose of a statin, here's the 2-year and the 5-year event rates on 80 milligrams of atorvastatin. Even that doesn't eliminate significant cardiovascular residual risk. So what is the residual risk? Well, it's probably a complex set of things, but a lot of the lipid people are looking at, well, is it because we lowered LDL, but we didn't affect triglycerides or HDL very much? Maybe it's HDL. Well, there is some data to suggest that low HDL does contribute to vascular events. Here are patients on 80 milligrams of atorvastatin in the TNT secondary prevention trial who had LDLs less than 70, followed for 5 years. If your HDL was less than 42, you had higher event rates than if your HDL was higher than 42. So maybe low HDL is a residual predictor of risk, even when you're taking an adequate statin and have an adequate LDL cholesterol. Then the Jupiter trial comes along and says, whoa, hold on a second. In primary prevention, we see in the dark blue in the placebo group that the lower your HDL, the higher your risk, obviously, the inverse relationship. But you know what? When you take a statin, that goes away. So maybe HDL isn't important. If you just take a statin, lower your LDL, HDL isn't important. But there is data to suggest, and the dark blue, the dark lines compared to the lighter lines, suggest that even on statins, there's still an inverse relationship. This is a meta-analysis in Annals last year. There's still an inverse relationship of your on-treatment HDL to future coronary events. So that's why there were several trials looking at whether trying to raise HDL would be beneficial, and we'll talk about that in a moment. Triglycerides are another lipid particle. Triglycerides don't get in the artery wall. Triglycerides are energy source. They're different than cholesterol. But triglycerides do predict cardiovascular disease. If your triglycerides are above 150 compared to less than 100, you have a 70% higher incidence of cardiovascular disease. So triglycerides predict something. Here's an outcomes trial in acute coronary syndrome patients treated with high-dose atorvastatin versus lower-dose pravastatin. Yeah, if you had an LDL that got down, you had a better event than if your LDL didn't. But you know what? If your triglycerides were lower than higher, you also had a better outcome. And statins don't lower triglycerides that much. So triglycerides are predicting something. So should we be treating them? Well, that's going to be a difficult task because there isn't a lot of data to support treating triglycerides per se. But what I'm going to tell you is that triglycerides predict cardiovascular events because they're telling you something about the lipoproteins that are in a person's plasma. You know, we talk about LDL cholesterol. That's an ApoB containing lipoprotein. But you know there are other ApoB containing lipoproteins, and those are the triglyceride-rich lipoproteins. So that's partly when we look at LDL, we are measuring the majority of the cholesterol that's in your plasma. But you know, cholesterol is carried in these triglyceride-rich lipoproteins as well. Non-HDL cholesterol is exactly what it says. It's the cholesterol that's not HDL. So it's the cholesterol carried in all of the purple segment here. Okay? So if you take all the cholesterol and subtract the HDL from it, that is non-HDL cholesterol. So it's a better marker than LDL of true atherogenic particle number. And that's why non-HDL cholesterol is probably going to be on the guidelines as something that you're going to need to look at and consider treating. Non-HDL cholesterol is no more than 30 milligrams above your LDL. No more than. If it is, it's because you have high triglyceride-containing lipoproteins. And you need to lower non-HDL cholesterol. At any given LDL cholesterol, pick it in the front, any given LDL, if your non-HDL is more than 30 milligrams per deciliter higher than that given LDL, you have additional cardiovascular risk. So triglycerides contribute to cardiovascular risk not because triglyceride gets in the artery wall. It's because triglyceride is a marker of a metabolic system that produces small HDLs and small LDLs. Many of our patients who have high triglycerides have metabolic syndrome. Visceral adiposity, they present free fatty acids to the liver in large amounts. That gives you fatty liver for many of our patients with insulin resistance, but it also overproduces triglyceride-rich lipoproteins. Intravascular remodeling of LDL and HDL with neutral lipid exchange between all these particles produces small LDLs and small HDLs. In other words, your HDL cholesterol and your LDL cholesterol look low. The number of particles, however, is not low. Here's an example. Here's a person right here with a total cholesterol around 200. Here's one slightly higher than 200. LDL cholesterols are exactly the same in these two patients. What's different? What's different is that this person has high triglycerides and low HDL. This person does not. When you subtract HDL from total cholesterol, you get a non-HDL that's within 30 milligrams per deciliter of this person's LDL. When you do the same subtraction here, you get a non-HDL cholesterol that is more than 30 milligrams per deciliter from their LDL cholesterol. So what's the difference? Well, what the difference is that they have a lot more particles, but they're smaller LDLs. Greater number of ApoBs than this person, smaller LDLs, more number of atherogenic particles. So this is why non-HDL and ApoB are going to be better predictors of cardiovascular disease than LDL cholesterol, particularly in patients with insulin resistance. As you'll see, that the lower a person's HDL is or the higher their triglycerides is, the discordance between what the LDL cholesterol measures and the number of particles that are present. It's this discordance that's probably responsible for most of the residual risk in patients. You say, well, I lowered their LDL to 70. Well, you may have lowered their LDL cholesterol to 70, but you didn't lower their particle numbers anywhere near that much. And so that could be what we've been missing on residual risk, is we've been missing the reduction in particle number. I'll give you an example of insulin resistance. The metabolic syndrome patient, and this is from the Framingham Heart Study. If you take a look at the dark color, that's LDL cholesterol. The lighter colors are ApoB and LDL particle number. As you're increasing number of metabolic syndrome criteria, you see the discordance. They're all about equal predictors of particle numbers, but they become widely discordant the more insulin resistant you get. So I think that insulin resistance is going to be the key, and that's what the American Diabetes Association said 3 years ago in a consensus statement. They said if patients have cardiometabolic risk, in other words, metabolic syndrome and diabetes, you don't just have an LDL cholesterol goal or a non-HDL cholesterol goal, you also have an ApoB goal. They suggested all three in these patients with metabolic syndrome or diabetes. And I think in the new guidelines, that will be the case. One final thing about drug treatment, just to tell you, it's easier to lower LDL cholesterol than it is to lower ApoB. And that's something to remind you, is that you may lower LDL 50%, but you're never going to lower ApoB 50%, not with the same treatment. It's a lot harder to reduce particle number than it is cholesterol content. Just to give you an example, statins lower LDL cholesterol more than they lower LDL particle number. So do bile acid resins. But you know what lowers particle number more than lowering cholesterol? That's fibrates, niacin, pioglitazone, physical activity, weight loss, omega-3s, anything that lowers triglycerides will lower particle numbers more than it lowers LDL cholesterol. Actually, bile acid resins and ezetimibe lower both similarly, LDL cholesterol and particle numbers similarly. So it's important to know, if you're looking at just LDL cholesterol, you're going to say that fibrates and niacin, omega-3s don't do very much for LDL cholesterol. Well, they don't, but they lower particle number more. How do you identify primary prevention patients better? I told you that they may come up with some ideas about biomarkers. There are lipid markers. I talked about those, but the biomarker that probably will make the list will be high-sensitivity C-reactive protein. There are a bunch of other ones. I think markers of renal function are important, but your eGFR is probably going to be the most important. That's a measure of chronic kidney disease. But also microalbumin and albumin to creatinine ratio are all important to identify high-risk individuals. But C-reactive protein may be the one in primary prevention that will elevate the risk. The important thing is that measure it to identify risk. Maybe more than 2, maybe 3 milligrams per liter will be the cut point, but don't measure it after that. Here's an outcomes trial, a heart protection study with statins. And the outcomes were exactly the same regardless of where the CRP was at baseline or whether the CRP changed or not after treatment. It didn't matter. So don't measure it to follow up. Actually, the TNT trial, high-dose, low-dose atorvastatin in patients with stable CHD, found that on-treatment lipids predicted cardiovascular events over 5 years, but no non-lipid biomarker, none of these predicted outcomes at any atorvastatin dose. So using them or following them aren't going to really help you predict. I think the only thing that will work probably will be C-reactive protein. Let me talk briefly about chronic kidney disease. We had a couple of dialysis trials with statins, 2 pretty good statins in dialysis patients, non-significant reductions in cardiovascular events. Bottom line here, don't let your patient get all the way out to end-stage renal disease on dialysis before you scratch your head and go, should I prevent their heart disease risk now? The answer is no, you waited too long. In the SHARP study, which was just published in Lancet earlier this year in June, and was just the subject of an FDA review Wednesday, and the FDA reviewed the data for SHARP. This was where 2/3 of the patients were not on dialysis and 1/3 were on dialysis. So it's a CKD population with usually stage 3 CKD. They found that there was about a 15 to 17% reduction in major atherosclerotic or major vascular events treating with a statin ezetimibe versus placebo. And most of that benefit was driven by the non-dialysis patients. So they voted on Wednesday to give the indication for statin use in chronic kidney disease pre-dialysis. And I think that's reasonable. The earlier you catch patients on that slippery slope of cardiovascular risk, as the renal function's going down and the risk is going up, the better you have an opportunity to reduce cardiovascular events. I do want to talk about the ACCORDS trial from the lipid standpoint. You heard about it from the blood pressure standpoint. They didn't find a benefit of more intensive blood pressure control versus less intensive blood pressure control, except on stroke. Well, in this trial, they looked at intensive statin treatment versus statin versus plus fenofibrate, a fibrate. These were the baseline lipids, and actually most of us would probably not have given a fibrate to somebody with a triglyceride of 160, but the bottom line was, although the blue line here was the combination drug treatment compared to the statin alone, although there was a trend on the primary outcome and all-cause mortality favoring the combination, it was never statistically significant, except in a subgroup, just like they found in the Accord blood pressure, except the subgroup of patients who have exactly who you'd give a fibrate to, high triglycerides and low HDL. If you have type 2 diabetes on a statin and you have high triglycerides and low HDL, adding a fibrate reduces your vascular events by 30%. So that subgroup does work, similar to the reduction in stroke and blood pressure. The niacin trials, I'll show you the AIM-HIGH study was stopped because of futility. I'll talk about that briefly. There's another huge trial, not done in the United States or North America, called the THRIVE study, which is a statin alone versus statin plus niacin in very high-risk individuals that should be completed next year. But the trial AIM-HIGH done in North America was stopped. High-risk individuals with low HDL, all treated to an LDL of 70 with a statin, everybody. And then they added niacin versus placebo on top. And they stopped the trial after almost 3 years because it was futile. There was no difference. So in this situation, what you find is that if you lower LDL enough, maybe HDL isn't that important. We're going to probably find that the actual on-treatment LDL is going to be 65. So it's an incredibly well-treated patient population. And adding niacin didn't seem to add anything. Last thing, I get asked this question because there have been 3 meta-analyses in the last couple of years using different groups of studies, but they're all using statin trials, one in Diabetes Care, Lancet, and one in JAMA just a few months ago, showing that statin treatment increases your risk of new development of diabetes anywhere between 9 and 13%. This is physician-diagnosed diabetes, not oral glucose tolerance-defined diabetes, not A1C-defined diabetes, physician-diagnosed diabetes. But there is a significant risk of getting diabetes on a statin. Very interesting, huh? There's no data that statins cause insulin resistance. But nevertheless, there seems to be a slightly higher risk of developing diabetes. The question is that enough of a reason to not use a statin? I think I've shown you enough data to show that that probably isn't. The benefit, number needed to treat, far outweighs the number needed to harm under these circumstances. We can talk about that in the Meet the Expert. What I want to end on is that the meta-analysis from the Cholesterol Treatment Trial is collaborative, 170,000 patients. You lower LDL cholesterol 1 millimole per liter, 40 milligrams per deciliter. You reduce all major coronary events by 20%, all-cause mortality by 10%, with no lower limit on the LDL cholesterol. There is residual cardiovascular risk after statin treatment, and low HDL might be part of that, but also triglycerides may be part of it, and that the triglycerides are a marker for increased numbers of atherogenic particles, particularly in patients with insulin resistance, and that's why non-HDL cholesterol is probably going to incorporate these things in non-HDL cholesterol, and probably even ApoB as a better predictor in patients with insulin resistance, and I think that's what they'll do in the new guidelines. I do think that targeting those two is going to be necessary, and that maybe niacin and fibrates and intestinally active drugs might be helpful on top of statins to achieve these targets after LDL. And last but not least, primary prevention needs to be appropriately identified candidates, and I think that women certainly fall into that, and men and women over the age of 70 should not be excluded from the benefits of statin treatment if they're otherwise healthy and functioning.